So this PowerPoint is on gastrointestinal disorders in children, chapter 15 in your textbook. Remember to look at the highlighted information. That's information you should probably know. So our learning objectives for this is to identify the manifestations of dehydration in nursing care, describe the causes of NEC, most common manifestations, and nursing care, and to be able to differentiate the different pediatric GI defects, manifestations, and nursing care. So we start with dehydration, mainly because most of these GI defects in children can lead to dehydration if it's gone on too long. So the definition of dehydration is when the body loses water and nutrients faster than they can be replaced normally. We have to be concerned with our infants or newborns when they become dehydrated because they have much smaller reservoirs of water in their body. Infants and young children, especially when they're ill and they're depleting fluids rapidly, become dehydrated more quickly than an adult will. So I listed here the common pediatric symptoms for dehydration. You'll note that many of them are underlined, and those are the more serious situations, I guess you could say, that we see when we talk about a child with dehydration. Of course, sunken eyes can be anyone, but it's the sunken fontanelle in the child under 18 months that is frightening. We talked about increased cerebral edema when we see the bulging fontanelles. Well, now with dehydration, we'll see sunken fontanelles. The child may be lethargic or just not active at all. Generally, with dehydration, we'll see tachycardia. With little children over 2 months, under 2 months, most little children don't have tears, but 2 months and above do. So when they're crying, they have no tears, they're dehydrated. With little ones at home, we ask the parents how many wet diapers have they had in the last 12 hours. If it's just starting, that's one thing we say, please just put a little tally down every time you change a wet diaper. If they're in the hospital and we're looking for dehydration, we look at a baby who is having less than 1 milliliter per kilogram per hour output. They'll have dry mouths. They won't have any saliva. Their mouths will be chapped. Their mucous membranes will be dry. Sometimes we'll see like a furry tongue and dry chapped lips. They'll have a poor skin turgor. Capillary refill will be 4 seconds or greater. And a lot of times we'll see weight loss. On the right side of your slide, you see the possible complications or what happens to our electrolytes in our little children when they become dehydrated. So in children, we have levels of dehydration. A child that's mildly dehydrated, you can see the percentage here that's listed. They can be treated in the ER. The family can be told what to do, and they could probably return home without extreme measures. They'll have a normal behavior, normal mucous membranes. Their fontanelle, if it's a baby, will be normal, and their pulse and BP will be normal. The capillary refill will be 2 seconds or less, and they may complain of slight thirst, and they might guzzle down water or Pedialyte, whatever we give them. These kids are not serious yet, and they can be told to go home and drink small, frequent amounts of fluids, no juices, and see how they're doing in 24 hours. A child who has moderate dehydration, for a child, it's 6 to 8%. For an infant, it's 6 to 9%. We're getting a little bit serious here. Depending on the behavior of the caregiver that brings them in, these kids could probably go home with some strict instructions. What we see with them, though, is weight loss, a little mild manifestation of dehydration, such as capillary refills between 2 and 4 seconds. They may be irritable, complain of thirst. Their pulse may be slightly more rapid than normal. We may see that when they stand, they have orthostatic hypotension. They could be just a little tachypnic. Their mucous membranes may be dry, and they have tears, but not very much. Their skin trigger, it's okay, but it's not great. And normal to slightly sunken fontanelles. Usually, if it's an infant, they will go ahead and be admitted. If it's a child, if the parents are on top of things, they may be able to go home and be watched closely and followed up with their own family doctor. That's an iffy situation, the moderate dehydration. But then the severe dehydration, it's 10% or greater, and these kids need to be admitted. Their capillary refill will be 4 seconds or greater. They'll definitely be tachycardic, and they will have an orthostatic BP, and they can quickly progress to shock, so they need to be watched quickly. They need to be rehydrated. Extreme thirst is their complaint. Mucous membranes will be dry, their skin will tint. Hyperpnea we'll see. They will have no tears, and their eyeballs will be sunken, and their anterior fontanelle will definitely be sunken. They'll either have very little urine output or no urine output. That is the severe, and that's 10% or greater. Those children will definitely be hospitalized. The moderate dehydration children, it depends on the kind of care they're going to get at home. So nursing care for a child that has mild dehydration. Accurate eye and nose and daily weights is a must. Assess the capillary refills with all their vital signs, and observe for lethargy. If they're mildly dehydrated, they can have oral rehydration, and it can usually be taught to the parents, and the parents can usually take this child home. The child will generally be NPO for 2 to 3 hours to let their tummy rest. Either Pedialyte or another oral rehydration is usually given at 1 tablespoon every 15 minutes for 1 hour. If they tolerate that, they can be advanced to 30 mils every 15 minutes for 1 hour. If they tolerate that, they can begin clear liquids, but go very slowly. No juices or dairy products should be given. And we no longer advance them to a brat diet. We actually will go from clear liquids back to the regular diet. If the child is breastfed, after they do the 15 minutes and then the Q30 minutes, they can resume breastfeeding. So this is a little chart just to explain the 3 different types of dehydration: isotonic, hypotonic, and hypertonic. We mostly see isotonic in children where, they have like gastro symptoms, vomiting and diarrhea, and water and sodium are lost in equal amounts, and it doesn't really affect their electrolytes. The danger of this is hypovolemic shock because they're losing so much fluid. So we watch them closely for their blood pressure and their vital changes. Excuse me. The hypotonic can happen. I think we see this more with burned patients. And they lose a lot of electrolytes, actually more than their fluids, so that their electrolytes are out of whack. Unfortunately, the shock is most likely to definitely occur in this situation. The child that may have hypertonic dehydration, they have water loss, which is greater than their electrolyte loss. So sometimes their electrolytes will be elevated in this situation. We don't see shock as often, but we do see neurological changes and signs of increased intracranial pressure. So care for a child that's moderate to severe dehydrated. These children will probably be admitted. Sometimes, like as I said before, the moderate may not, but we're assuming that they are moderate to severe. Of course, once again, accurate I&O and daily weights is important. Assessing the capillary refills along with their vital signs is very important. We'll watch for signs of lethargy. And if they're moderate and they can keep fluids down, we may start using oral rehydration right in the hospital and see how they do with it. But the severely dehydrated child will need IV replacement fluids. And we usually start with the isotonic solution of 0.9 normal saline. Doing pretty well with that. They're starting to perk up. It's usually followed the next bag with D5 0.45 or half normal saline. And usually at this point, the child has voided, and if needed, we can add electrolytes to their fluid, and usually the one we're looking at is potassium. The child needs to void. We need to actually see it before we can give them potassium. We do replacement fluids over 24 hours. A few of you in clinical, I've kind of showed you how to do it. The rest of you, I'll spend a couple of minutes in class showing you how to do it. One thing with children versus adults will come in dehydrated and they'll just open the bag of fluids and get them hydrated quickly. We can't do that with children. It can cause cerebral edema and fluid overload. So all replacement is done over a 24-hour period in a child. Okay. Gastroenteritis is some kind of an infection in the gastric system. Generally, we see it mostly with diarrhea, but it can be diarrhea and vomiting. So the manifestations are on the left. A severe child, we call it gastro for short. With gastro, we'll have blood or pus in their stools, and we become a little nervous. They'll have the signs of dehydration that we mentioned before. And gastroenteritis can last in a child 2 to 10 days. Risk factors for it are listed on the right. Poor hygiene, maybe. Crowded living environments, sometimes that could just be daycare. The kids are kind of close together. Or it could be, living in a bad situation. Poor sanitation, definitely. And nutritional deficiencies, which keeps us protected, sometimes is missing and can, the child be more susceptible to gastroenteritis. So there's three, again, categories. There's the acute, the chronic, and the acute infectious. So the acute is just the child has a sudden increase in frequency and change of their stool. Their stools become watery. I think the actual diagnosis of diarrhea, which I couldn't find in your book, is more than 3 stools a day for more than 3 days. So a lot of times the acute diarrhea will be from a GI infection, sometimes from an upper respiratory infection, all that mucus drains and causes loose stools. Many times we'll see kids with a urinary tract infection have acute diarrhea. It's the pressure on the intestines that causes the UTI. Sometimes it's because it's a small child and they're in a diaper, and so the stool will get all over, all aspects of their perineum, and so stool will get up, in the renal tubules. We see it from antibiotic use, and we see it from excessive laxative intake, like for those anorexic or girls or boys. Chronic diarrhea is interesting. Here's a list that can cause it. This is kids that have a change in stool for more than 14 days. And actually, it usually goes on, and it can go on up to a year. And if the child doesn't lose weight, we treat the symptoms and keep a close eye on them. Most of the time, they will gain weight if they have chronic diarrhea, but we don't want them to lose weight, of course. So some of the causes could be malabsorption or food allergies, inflammatory bowel disease, and sometimes it's idiopathic. And what we find a lot of times is these kids had started off with a virus that caused diarrhea, and it gets better. It goes away like it should, but the lining of the intestines has been slightly damaged from the virus, so it no longer allows stool to accumulate, and in fact, it just kind of pushes it on through. As that lining heals, the chronic diarrhea goes away, but it can be months in the child. And in chronic diarrhea, it's just an increase in frequency and change for 14 days or more, but it isn't, 3 or 4 or 5 loose stools a day. It's usually once or twice a day. The child with acute infectious diarrhea generally has been exposed and has picked up a viral, bacterial, or parasitic infection. These are the pathogens we see in the acute infectious diarrhea. Note one on here, the vermiculus. The other name for that is pinworms. It actually could cause a little diarrhea, so it falls into this category, but generally what it does is it causes the child to have an itchy rectal area, and mostly at night when the mother bug, pinworm, comes and lays the eggs at the edge of the rectum, and it'll wake the child up, excuse me, and the child, if it's a baby, will be irritable and crying. If it's a little toddler or preschooler, they'll complain that their bottom itches. What they do for the pinworms is they'll put some very clear Scotch tape, make an X over the rectum, leave it on all night, and in the morning take it off, and you can actually see the eggs, which are very, very small, microscopic, but you can see them on the clear Scotch tape. Now, many times the doctor will tell the parents to do this at home and to bring the Scotch tape in a little jar to the office the next day, or take it to the hospital and they'll plate it out. Tests that can be ran to see if the child has a infectious diarrhea or gastroenteritis are listed on the left, and the right talks a little bit more about the pinworms and the medication for the pinworms. So a CBC, because sometimes these kids become anemic during that, or they have an infection somewhere else. It's not one that we're looking for. The hemoglobin, the hematocrit, the BUN, the creatinine, and the specific gravity will be elevated if the child is dehydrated. They'll check the stool for occult blood, they'll do stool cultures, and they'll do a stool for ovarian parasites. It's different than the stool culture. The stool culture can be put in a sterile container and kept in the refrigerator overnight and taken to the lab in the morning if this is an outpatient. However, the stool for ova and parasites needs to be put in a sterile container and taken immediately to the lab, and it needs to be plated out while it's still warm. I think you have 2-hour window to get it to the lab. And then again, they'll check the UA to make sure the child doesn't dip positive for bacteria and need a urine CNS, and maybe that's the cause all the way around. The diagnostic procedures, one is the tape test. And if the tape test is positive, the child will be given this medication. And not only will the child be given this medication, but the entire family will be treated. And the parents are instructed to vacuum the house, to vacuum the mattress, throw away the vacuum bag, clean sheets, clean towels, and the child needs to take their clothing off in the tub and shake it out in the tub, so that if there's any eggs on their clothing. It's not dropping down onto the floor. This is kind of a problem with daycares is children will have it in their underwear or their diaper, and they sit on the floor, and the little eggs can, I guess, roll out into the carpeting or whatever, and the child puts their hands in their mouth. They can pick up and ingest a pinworm that way. So once one child has it, it usually runs rampant in a daycare situation. This slide talks about the different infectious diseases that can cause diarrhea in children. What I really want you to know is some we just do blood with, and sometimes we have to draw blood and do stool cultures. So I think you might want to put it into a couple categories, like this is what we do for this guy, this is what we do for that guy, just so that you have a good feeling on where we might see the pathogens and be able to help make the diagnosis. The nursing care for a child with a pathogenic infectious gastro, whether it's a parasite, bacterial, or viral, is about the same. We need to get their height and weight to start with, and then check it daily. INOs is important, and that includes stool INO. Nothing to irritate that gastrotract, so no rectal temperatures. IVs if they're prescribed. The antibiotics for the Shigella, C. diff, and Giardia are listed, but we want to be careful. There's no antibiotics that will help the botulinum, the E. coli, or the Salmonella. We have to let it run its course. We never give anti-motility agents to these three because we do want it to run its course. One of the common viruses that we see that causes diarrhea is the rotavirus. It's the most common infection that children under the age of 5 get. Most people have had it by the age of 5, and it's the number one reason children seek help for diarrhea in the hospital or the doctor's office. It's very contagious, and it can be transmitted easily. We see it really in the young children, but adults who've never had it can get it as well. They're just usually not quite as sick. Although it's severe diarrhea, it can be treated at home. There's no medication for it, and we just treat it with steps to prevent dehydration, and we follow the mild dehydration protocol for it. It can have serious complications, which is severe dehydration. And the infants, there's a injection for it, a vaccine, the rotavirus vaccine for infants. Generally, the symptoms will start about 2 days after the child's been exposed. And initially, they'll have a fever and a little vomiting, but then it'll be followed by a week, usually, of severe watery diarrhea, 3 to 7 days. It starts with vomiting. The stools will become really watery, black, or tarry. We'll see blood or pus in them sometimes because it's so, severe. The child will become fatigued and have a fever and be crabby. We watch for symptoms of dehydration. One of the things that is real common is the abdominal pain. The kids will have a lot of tummy cramping. Rotavirus is very, very common. Most children by the age of 5 have had a bout of rotavirus. So in general, education, not only for the rotavirus, for any of the infectious gastroenteritis, wherever the child is, most of the time needs to be notified, whether it's the daycare or the schools. While the child has the diarrhea, they need to be at home. There is over-the-counter prepared oral rehydrating solutions such as Pedialyte, Oralite. We don't really suggest Gatorade or some of those. The sodium content is high. They may not need that sodium content. The sugar is high in it, and we just feel that sometimes something that has sugar in it can cause the diarrhea to worsen. If the we teach the parents how to take care of their skin, and we also teach them, strict hand washing to avoid the spread of diseases. We remind them that there's an immunization if it's an infant for rotavirus, although it's got to be given pretty early in life. We don't want them giving children fruit juices. Anything that's sugary will increase the diarrhea. So fruit juices, soda, gelatin, anything really high in carbs, but low in electrolytes, we just want to stay away from. In general, broth is high in sodium and it doesn't have enough carbs. So when the parents advance them to a clear liquid diet, as you know, broth is usually given in a clear liquid diet. So they can do that for a short time, maybe 1 or 2 feedings, but not for very long. The bread diet has low nutritional value and people tend to keep their kids on it way too long, and we just don't think it's a good idea. And remind them that caffeine has a mild diuretic. So to be careful if they give them tea, that their tea doesn't have caffeine. And that's another reason the bread diet, has tea in it as well. We want to teach them about changing the bed linens and the underwear. If they have some kind of a pathogen, don't shake it. They need to clean the child's toys and child toy area. Therefore, toys that can't be washed aren't a good idea during this time. Keep their nails short, so if they're scratching, and keep those bathrooms clean. The child needs to shower every day and frequently. And teach the parents to avoid undercooked or under-refrigerated foods that can cause a pathogen. Educate on proper hand washing, and there should be no sharing of food or drinks at this time. So the next thing we're going to talk about is necrotizing enterocolitis, or it's better known in the NICU as NEC, N-E-C. We mostly see it in premature children, although it could be any neonate. It's usually a baby that's born weighing less than 800 grams. It's a very serious situation that causes the intestines itself to create ulcers or perforations in the intestinal wall and tissue necrosis. It can also progress to septicemia, which I'm sure you realize in a premature or a brand new neonate can be a big problem. It generally, but not always, will affect the lower portion of the small intestines. And thank goodness it's less common in the colon and the upper small bowel. Again, we see it in premature babies. We see it at neonates that were very small and had some complications at birth, such as breathing issues, feeding issues. In babies that have intrauterine growth restrictions, we see it. And those babies that had needed, because of the HBO and ABO incompatibility, we see it on those that had exchange transfusions, or those babies that need to be enterally fed. There's some thought with this that we feed in America, because it's a higher incidence in America, our babies a little bit too early, and by doing that we cause gastric acid to form and the perforations in the walls of the intestines. No theory has been proven to be quite the answer yet, but all these other situations have led themselves to being causes of NEC or risk factors. To diagnose it, they'll usually do an abdominal x-ray, and they'll do some labs. Usually the baby will have a swollen abdomen. They'll begin having bloody stools and not want to eat. They'll then progress to vomiting, bile stain emesis. The children are usually lethargic, And if it's an NG feed, which sometimes, the NICU baby is initially, there'll be a high gastric residue. They'll pull back on the syringe before they start the next feeding. Now they do it routinely, actually, to see how much of a residue. If it's quite a bit of a residue, they think, oh my goodness, this baby, is at risk right now for neck. We find it to baby that apnea worsens, they're hypotensive and anemic. The child generally will go into metabolic acidosis, and sometimes they'll have leukopenia. A sausage-shaped dilatation of the intestines can be felt. And when they look at the bowel wall, there is what they call a bubbly appearance of thickened bowel wall, or the pneumatosis. The child usually has a hard time keeping their temperature up, and they have a decrease in urine output. Out of these, when a NICU nurse is going to feed the baby, they notice their abdomen might be a little swollen, and they will, once again, if it's NG, they will check to see what the residual is. If it's quite a bit of a residual, like almost the whole last feeding, they usually right then and there will stop and report it so that the diagnostic procedures can begin for neck and the child can be treated before all of these other situations begin. So one of the first two symptoms is swelling or bloating of the abdomen and the high gastric residual, followed by bloody stool and poor feeding. So a nursing care for a baby diagnosed with NIC is generally they'll be NPO for 24 to 48 hours to rest their gut. Now, there's some places where a breastfed baby could still breastfeed. Generally they don't get as much. Remember, this is a brand new baby. So if mom doesn't put the baby to the breast, her milk will never come in. So whether the baby gets anything or not, it'll be very little. They'll generally put the baby on NG to low intermittent suction. And after looking at their labs, they'll correct any imbalances in their labs. Oxygen will be given. And then at that point, the poor little guy will have abdominal x-rays every 4 to 6 hours. If it looks pretty serious and the perforations are increasing, then many times they'll go to surgery to remove the necrosed bowel, and they'll put in a temporary colostomy to rest the rest of the bowel. The nurse needs to monitor for the bowel sounds, residual, gastric residual, and stools. She'll take a look at the blood pressure and the vital signs. Now remember, doing blood pressures on infants is not that common, but in this situation it's needed. She'll monitor the oxygen and the blood gases. Never is a rectal temp taken. They keep the baby on diapers so that there's no pressure on that abdomen. And every 4 hours or before the baby is allowed to feed again, before every feed, they'll measure the abdominal girth. They're hoping to see it go down. If it goes up, some more necrotizing situation, is intimate. So they're afraid they're going to lose more of that bowel. Of course, strict hand washing, daily weights, and INO. And the nurse will monitor for septicemia, DIC, and hypoglycemia, which are the complications of NEC. Parent education for this. As you know, parents are they're often in the NICU. So if this baby is a new baby and the mom hadn't decided whether to breastfeed or not, the nurse needs to encourage her to breastfeed because of the protective qualities that breast milk has. If the baby is going to have surgery, the nurse is wise to teach the parents about the surgical intervention and afterwards the long-term care such as colostomy care. Emotional support is needed for the parents and answer all their questions. About 15, 20 years ago, this was a huge problem, and babies most of the time ended up in surgery for it. Nowadays, we figured out symptoms for it or manifestations, and it's caught earlier, so it doesn't always end up to be quite so bad. The other thing that is done, and I think I did find it in your book, is many times they isolate these babies from other babies because they're still not 100% sure of the cause of it and whether it is contagious. The next thing that falls into this category, I know you might think this is funny, talking about the head, the face, but it has to do with our gastrointestinal tract. So it's the cleft lip and cleft palate. So the lip is a little opening that most of the time will go through the lip and into the nose during utero. It just doesn't fuse together. It can be one side, it can be both sides, or it can be right in the middle only. The lip could be by itself, or it can accompany a cleft palate. Now, if there's no cleft lip and the baby has a cleft palate, that is a little bit trickier to detect. A cleft palate, the roof of the mouth doesn't join completely together during pregnancies. And it can be the front and the back parts or just one. The symptom of a cleft palate alone without the cleft lip will be, and important to know this, when the baby is fed, if they have a cleft palate, the formula will come out their nose. It will not go down because of the opening. It will come out their nose. So a cleft palate is not always diagnosed at birth unless a cleft lip accompanies it. One thing is people, when they have a baby with a cleft lip and palate, they are very emotional about the situation because the baby looks different. So the first thing we need to do is assess whether this is going to be an issue or not. One of the things nurses can do is to, hold the baby, love on the baby as if it's the most beautiful baby ever, the person's ever seen. And let the parents know that this is still the perfect little newborn they wanted. And this can be fixed. This isn't a life sentence. Sometimes you have to help the parents. And most psychologists tell us to point out the baby's positive attributes and remind the parents how lucky they are that this is the only thing wrong with their baby. You want to instruct them on feedings. Feeding a baby with a cleft lip and palate is a little bit more tricky. We'll talk about that in a minute. The nurse needs to assess the baby's ability to suck. And once you teach the parents how to feed this baby, you need to see if they're going to be able to feed this baby at home. Weight's very important because that'll tell us if the baby's getting enough. So baseline weight. Every day or every shift, the lip is inspected using a gloved finger, never tongue blade, never anything else should go in this baby's mouth. This may be a lot of surgeries, and generally it is. So social service can help the families with their financial issues. And there are support groups for this because this can be devastating for a parent. So with the cleft lip, we do encourage moms to try to breastfeed, and we can actually sometimes put these wide-based nipples over the mom's nipple and help the baby to breastfeed. It works maybe 50% of the time. It doesn't always work. If not, moms can pump their breast and store the milk, and we can feed the baby the breast milk. So for just the lip alone, they need this special nipple that's wide-based. And we need to squeeze the little infant's cheeks together to help them form a good seal. A baby that has both the cleft palate and cleft lip, they need to be fed upright. They need a special bottle with a one-way valve and a special needle. And this is what's being used more often now, the Medela. and it's a great picture that explains it. These babies suck in a lot of air, so they need to be burped more frequently than you would a baby without a cleft lip palate. And sometimes they just need to be syringe fed if it's severe. So the chyloplasty is the repair of the cleft lip, and it's done pretty early, 2 to 3 months. Yes, the parents take the babies home, try to keep them healthy, try to feed them, and bring them back, but it's done at 2 to 3 months. And many times it needs revisions, although the newer surgeries have been great. The palatoplasty is the repair of the cleft palate, and it begins its repair somewhere between 6 and 12 months, and it's done in many, many steps. In fact, many times it's being repaired and revised until the child is like 5 years old. We need to remember that these children will have some pain, so pain management's important, and vital signs and oxygen levels are important. When they come back from surgery, if they have a cleft lip, we have to assess the operative side for signs of crusting and infection. And many times there'll be an order to put something like bacitracin or some kind of ointment to keep the crust away off of that suture line. When the baby first comes home back just from surgery, there's no sucking, there's no bottle or pacifier. They generally keep it NPO for a little while. Don't put anything in the baby's mouth. Daily weights. The nurse really needs to observe the family's interaction with the baby and look at their coping skills and make sure they're going to be able to take care of this baby at home. So post-operatively, the cleft lip, the child may come back, and I'm going to tell you I don't see it as often anymore, with what they call a Logan bow. And it's a little apparatus that they put after they, have the suture line intact over it so that the face area forms naturally and it looks normal. But many times now they're finding that a butterfly adhesive is just as good. And I wrote it. It prevents tension on the suture line, so it would form, it heals naturally. The baby needs to be on his back in the upright position, like a 30 to 45 degree angle, or a car seat can be used. The baby will come back and should keep on elbow restraints so the baby can't touch the operative site. Remember, when you're with the baby, you can remove the restraints and assess the skin and exercise the arms, but the restraints need to go back on. At all children's, they call them no-nos, N-O-N-O-S, and I guess it means, no to touching the face, but that's actually the brand name of it. If there's an order, you can clean what do I want to say? The site with sterile water, sterile saline, to keep it clean, and follow with an antibiotic ointment. Generally aspirate the mouth and the nasopharynx to prevent respiratory problems. Now, the post-op cleft palate, which is done later, the baby will come back from surgery, and many times he may be on his tummy, on his abdomen, post-operatively, so that all the drainage can come out. You won't see a baby with a cleft lip on his abdomen because we don't want him rubbing his face in the sheets, but a cleft palate may be. The baby needs to be changed, the position needs to be changed frequently to help with drainage and breathing. Generally, they'll have an IV fluid until they're able to eat. Once they're able to eat, now remember, this is a 6-month-old and on. Don't give them a straw, a tongue depressor, utensils, a hard tip reciprocup, or don't use any suction catheters in his mouth. He'll have restraints, And you want to always observe for airway obstruction because a lot of times postoperatively, these babies have a lot of secretions. They'll generally put a face mask on to deliver oxygen initially and clear liquids once the baby can eat for the first 24 hours. So after the baby has their surgeries, you'll have to instruct the families that's going to take them home about the elbow restraints, about the diet and the feeding information, and how to care for the wound. Complications as aspiration, ear infections, and hearing loss, which is any child with a cleft lip palate because of where the wound is. They usually will have a speech and language delay, and all the time. I've never known a baby not to have dental problems. So the intra-collaborative care would be with the plastic surgeon. You'll help the parents with an orthodontist, an otolaryngologist, a speech pathologist, an audiologist, social worker, and generally there's a little bit of a psychologist involved. Reflux, gastrointestinal reflux, or GER, GERD. GER is when the gastric contents reflux back into the esophagus. The esophagus is vulnerable to injury from the gastric acid, so we look for manifestations of that. GERD is just the reflux, GE reflux, GER. But GERD, is when there's tissue damage from it. The gastric acid has caused tissue damage, and that's the difference in the two. So be careful when you're in the hospital and the baby's diagnosed with one. It's not necessarily both. Keep an eye on that. Okay. If it's gastrointestinal reflux disease, 99% of the babies, it will resolve by the first year of life. What usually happens with these kids is as they suck, their formula breast milk and it's going down, the sphincter that lets it go down to the tummy is a little muscle. And sometimes babies are born with weak muscles. So it goes down, but that particular sphincter is weak, so it opens. And before the formula breast milk can be digested, it comes back up through the esophagus. It can happen right after the baby eats or several hours later. As it comes up, most babies will spit up a lot, or it'll burn their esophagus and they'll cry. We worry with these kids that it's going to come up and go into the trachea. So that's really the danger of it. This is the most frequent reason that parents take their babies to a pediatric GI specialist. The risk factors for this is premature infants, infants born with other congenital diseases. So remember, it comes back up. And when we say it's self-limiting and it will go away by itself, generally it does. As the other muscles in the body get stronger, so does the sphincter. So eventually the sphincter gets stronger and we don't see it happening anymore. Generally, it's about the time that the child is walking that we see that sphincter has healed. So in infants, we see them excessive spitting up. They're irritable. Sometimes they'll have blood in their emesis or stool, and that tells us that it's GERD, G-E-R-D, and it's irritating to them. Sometimes we'll see them arching their back. It almost looks like, a little bit of a seizure. Sometimes babies won't actually spit up, but they'll make this like swallowing sound. Then they'll arch their back and cry. And the formula is coming back up, just like the baby that spit it out. But they're not spitting it out and it's going back down, and that's what that swallowing sound is. We have found GE reflux related to apnea, failure to thrive, bleeding problems, and difficulty with swallowing. The older child will have similar symptoms if it doesn't heal quickly, but we see them with heartburn, abdominal pain, difficulty swallowing, and sometimes a chronic cough. They'll sometimes complain of chest pain, and it's non-cardiac. And generally when an older child has this, it's because they're eating too much at one time and it's forcing that sphincter open. Complications could be a pneumonia because it goes back to the trachea, weight loss if it bothers the baby too much, and failure to thrive. So they'll do some GIs series that are all listed here. They'll do a pH probe and an endoscopy. Interesting enough, a baby that is spitting a lot should be seen in their own pediatrician's office. And the first thing that we do is to review their feeding schedule. Are they feeding too much, too close together? The second thing we do is weigh them. If they haven't lost weight, we are okay with this GE reflux and there's things we can do. However, if a child has lost weight, which is really not common, happens, I don't know, 1 out of 1,000 babies. They need a surgical manipulation, and it's called a Nissen fundoplication. And it's where they wrap the fundus of the stomach around this distal esophagus to decrease the chance of reflux. To keep it down is actually what it is. And I love this picture because it's exactly what it said it is. This is only done, once again, if the baby has lost weight. 9 times out of 10 don't. So based on how bad the symptoms are, we teach the parents to offer small, frequent feedings of thickened formula. Usually it's a teaspoon of rice cereal to an ounce of formula. One of the formula companies now makes, I think it's the Ross company, makes a formula that has rice cereal in it, but it's not thickened enough. It helps real mild cases, but it doesn't help many babies. If mom is breastfeeding and or if it's an older child, they are to avoid caffeine, citrus foods and fruits, peppermint or spicy foods. The child can have the head of the bed elevated 30 degrees while eating, or when we're feeding them, we hold them in an upright position. The SIDS Foundation and the American Academy of Pediatrics have given permission for babies with SIDS to be placed in a prone position at night or for sleep so that it prevents aspiration. Remember, we don't put them in car seats because it's too high up of a position. 30 degrees is ideal. We used to put these babies in a car seat after we fed them and have them hold real still. And what they found is by sitting like that, and you know how a baby's spine, the baby like kind of, clumps forward a little bit and their chest kind of goes on top of their tummy. It actually makes it worse. If a child is crying with the reflux, it's assumed that they have GERD then, G-E-R-D, and that it is irritating the esophagus, and we don't want them to get esophagitis. So these are the medications that the child is given, but only if it's an unhappy baby. We usually use the term for a baby with GE reflux as a happy spitter. They gain weight, they can spit now or 2 hours later. It doesn't have any rhyme or reason to it. And they seem happy for the most part, unless they have some burning. I don't want you to get confused with the symptoms of that with the pyloric stenosis, hypertrophic pyloric stenosis. And this is where the pyloric sphincter is narrowed and thickened, and it creates an obstruction. It can be genetic, and we see it more in boys than girls. and it usually occurs in the first few weeks of life and rarely seen after 12 weeks. So some books say 2 weeks to 2 months, some say 3 weeks to 3 months. So we very rarely see it after 12 weeks, more common in boys. And we usually see it begin around between 2 and 3 weeks. So the baby's had his first visit to the pediatrician, has his weight taken, which is ideal because baby with pyloric stenosis actually vomit and they lose weight. So the symptoms are non-bilious vomiting, and it's projectile. It can hit the wall, and when you see a child do it, you'll know what I'm talking about. Versus the child that has GE reflux that just spits up less than an ounce. These kids usually lose all their cookies, and it usually occurs right after they've been fed. Sometimes it gets irritated, their throat gets irritated, and there might be some blood tinged. These babies cry all the time because they throw it all up and they're constantly hungry. We can actually lay the baby on his back and see an olive-shaped mass move in the right upper quadrant from left to right. It's pretty cool. And I wrote it exactly how you should remember it. Olive-shaped mass and right upper quadrant of abdomen. Possible peristaltic wave that moves from left to right when lying supine. So a parent calls and says, my baby's throwing up. You need to find out if they know the difference between a throwing up and a spit up. So bring the baby to the office and let's weigh the baby and let me watch you feed the baby. Bring it to the office, the first thing you'll do is weigh it. The babies with GE reflux will gain weight unless it's at 1 out of 1,000. The babies with hypertrophic pyloric stenosis will not gain weight. Failure to gain weight, and they'll begin signs of dehydration. Labs are drawn, the electrolytes to see what their sodium's doing. It's diagnosed by an ultrasound of the abdomen, and when they look at it, they'll see an elongated mass in the pyloric area. There's no other treatment except surgery. There's no way to fix this, and it needs to be done quickly because a child will really seep into deep dehydration. So preoperative care, generally for a day, the baby, if they have a day to wait, or depending on how severely dehydrated the baby is. I've had some that are just mild and they take them right to surgery. But the dehydration will be corrected. They'll put in NG tube for decompression, and of course NPO, INO, and daily weights. Post-operatively, the baby will come back from surgery and you'll check the vitals and watch for pain relief. Use the pain scale, the FLAC. They'll have IV infusion until no more vomiting. And it can be, 48 hours before the kid stops vomiting. The NG tube is removed after surgery. And once the baby's allowed to eat, we'll monitor their response to oral feedings. INO, daily weights, and monitor for infection. The next anomaly is intussusception. And intussusception is interesting. I wrote it, the definition is telescoping of intestines over itself, causing lymphatic and venous obstruction and causing edema in that area. If the baby's not treated, ischemia and increased mucus will occur, and actually they'll have to have their bowel resected. So we want to catch it right away. It's common in infants and children. The first known time to see it is 3 months until the child's 6 years. You could see it. So it's usually 6 months baby becomes severely irritated, and because the older child will tell you they have episodic abdominal pain so severe that he screams. you have to remember that sometimes babies, when they have gas pain, will scream and draw their knees to their chest. So you have to be realistic with it. So the next thing you can do is look at their tummy, and there is a sausage-shaped abdominal mass, again in the right upper quadrant. Okay, so remember, pyloric stenosis is the olive, and this is actually a sausage-shaped mass. You can see the intestines is what you're seeing. The stools for these kids will be mixed with blood and mucus, and some places call it red currant jelly. So if you remember, telescoping, severe abdominal pain, right upper quadrant, a sausage-shaped mass, along with red currant jelly, stools, you'll remember that it's a intussusception. The child will vomit and have a fever and have distended abdomen that's very sensitive to touch. They'll do an ultrasound, and generally they'll do a rectal exam, which reveals the mucus and blood. So interesting enough, and I've had a few kids in the outpatient world that has had this, and generally this is fixed in the outpatient world quickly. They give them some IV fluids if it's gone on for a couple days before the family has decided something's wrong with them. Otherwise, they'll get an NG tube put down for decompression, and they'll be taken to radiology. And while they do the x-ray to find out for sure this is intussusception, it usually will correct it. So the therapeutic procedure is an air enema. Generally, they'll just shoot air in there while they're looking at it under radiology, and you'll see that it untelescopes itself. Sometimes, if that's not working, they may use some contrast with it. It's a little bit thicker, a little bit more forceful, and that generally will fix it. If not, they take it to ultrasound and do a saline enema or a hydrostatic enema and see if they can fix it there. So Hirschsprung's disease is caused by the lack of ganglionid cells in parts of the colon, and it happens in utero when the parasympathetic ganglion cells that all of us have in the wall of our large intestines do not develop. And in this parasympathetic ganglion cells is the nerves that causes the colon to contract and relax and moves the bowel contents through so that you're able to go to the bathroom and poop. These kids don't have those parasympathetic cells. So we usually see it in infants. Every now and then, it hasn't been too bad, so we don't know if they had a few cells or whatever, and it's been kind of a problem all along. These kids haven't been able to poop, but if that's the case, we may be able to, it may last to later childhood, but generally this is something we see in an infant. And the risk factors of family. So one thing that's definite is the newborn will have delayed or will have no meconium stools in the first 24 to 48 hours. So this is the second pediatric issue where they had absence of meconium stools. The first one, if you remember, is cystic fibrosis. Okay. The baby will vomit bile and they'll refuse to eat, and their tummy will become distended. They'll become a failure to thrive. Constipation will be an issue. Vomiting is constant. And then they'll become to have episodes of diarrhea and vomiting because the colon can't spasm. Sometimes the stool will just go straight through and be liquidy. Other times it'll stop because it can't spasm and they'll become constipated. The child will have foul-smelling ribbon-like stools. So Hirschsprung's has ribbon-like stools. That's the classic symptom of it, ribbon-like stools. Where intussusception has the currant jelly stools. The child will appear undernourished and anemic. He'll have abdominal distension and visible peristalsis. It's kind of like their tummy spasming, because there's no ganglion cells there to control it. You can palpate fecal mass. Of course, you'll see it on x-rays as well. Electrolytes and CBC will be drawn to see if the child is anemic and if they're dehydrated. And they usually will do a rectal biopsy, and they can see that the colon is not performing. So they end up having to remove the ganglionic sphincter, and temporarily, most of the time, the child will get a colostomy for a while. The electrolyte and fluid replacement will be fixed, and many times these kids are undernourished and they need TPN. If not, their diet is important to know: high calorie, high protein, and low fiber. We monitor for enterocolitis, and we talk to the child if they're a little bit older, 4, 5, 6, explaining what's going to happen. Post-operatively, they'll come back from surgery, and it's normal post-op care, watching the airway, watching the vitals and the oximeter, controlling the pain, assessing the surgical site, Foley care. But it's important to assess bowel sounds and functioning, to do ostomy care and teach the parents, and also teach the parents how to care for the surgical site and signs of dehydration. The complications can be enterocolitis, which is an inflammation like an infection in the bowel. The kids get very, very sick, and they can lead to shock. So it's really, really important to watch closely for that post-operatively. We assess their abdominal girth to make sure it's not growing, and manage their fluids, blood replacements, vital signs, and antibiotics. The other problem that we see sometimes is the anal stricture incontinence. So now stool just leaks out of their bottom all the time. So if that's the case, the doctor will go in and do an anal dilatation, and then we put the child on a bowel therapy program. I'm not going to go deeper than that because it's kind of entailed, and we can talk about it another time. I just want you to know what I have here for you. Appendicitis. Many of you probably had an appy. So it's caused by the obstruction of the opening of the appendix. Generally, these are kids that have had stool problems on and off for a long time. The obstruction is usually caused by fecal matter or sometimes swollen lymph tissues. Once in a while, a parasite, but as I put here, that's very, very rare. It can cause peritonitis in the child and electrolyte imbalance and shock. The most common age we see it is 10 years old. The child will have severe abdominal pain, and it begins first at the peri-umbilical area, and then it rolls all the way down to the right lower quadrant, which is also called McBurney's point. To feel them, their abdomen is rigid. To listen, you'll hear decreased or no bowel sounds at all. Generally, the child will have a fever, not always, but they will be tachycardic, and they will be doing shallow breathing. Sometimes they have vomiting and they don't want to eat. A history of diarrhea or constipation and lethargy. This child, the pain is so severe when he walks in, he cannot walk upright. He'll be bent over. If it's a little guy, parents carry him in, when you lay him down, he will turn to his side and lay in the fetal position, pulling his knees up. This is hard to tell because some gastrointestinal viruses cause severe pain. In fact, Giardia has very painful cramping motions in the tummy, and those kids really hurt and cry, and so do these kids. So the way to tell it from generally some kind of a gastro problem and the kid having an appendicitis is ask them what came first, the pain or the vomiting. Generally, with all the gastrointestinal problems, the vomiting will come first and the pain will be secondary. With an appendicitis, the pain will be first, and then later on the vomiting will come. Generally, we do a CBC and a UA first. Then the child will get CT scans of the abdomen, and sometimes they get ultrasounds. They'll see the enlarged diameter of the appendix. Most of the time, laparoscopic surgery is done if it hasn't ruptured. But if it has ruptured, they sometimes will do open surgery. One of the symptoms that it's ruptured is real similar to your symptoms of a child with asthma that is now in danger. Remember the question, if you're taking care of a little child that's wheezing, profusely, and you leave the room from it, come back in and he's not wheezing, is he better? And the answer is no. In fact, he's worse. The air can't exchange. The same thing with this. The kid will be screaming with pain, and you leave the room for maybe a minute to get the doctor, get an order for pain, and you come back in, and he says, it feels a lot better. Maybe he should go home. Then it's probably ruptured. Okay. So nursing care before surgeries, IV fluids, and antibiotics. Remember, no heat to the abdomen, no enemas, no laxatives. Explain it to the child in appropriate developmental techniques. If it has ruptured, an NG needs to be placed for decompensation. Post-op care is keep an eye on the respiratory status post-operatively, and most of the time supplemental oxygen is prescribed and they'll come back from surgery with it. Monitor their vitals and pain and assess their surgical site for bleeding and infection. Most important, assess bowel sounds and function. They'll have IV fluids and antibiotics if it's ruptured. There'll be NPO and an NG tube to low continuous suction will have been placed. A lot of times it'll be open wound care, not always. Lately they've been closing some of them, but in general they usually leave it open and let it heal from the inside out if it ruptured. They'll usually have a drain, and watch them for signs of peritonitis secondary to being open in a drain. When the kid's going to go home, you have to teach the family how to take care of the incision, infection, and that the kid needs to get moving around so he doesn't get a pneumonia, and what kind of diet to go on. In general, when they're in the hospital, once their bowel sounds return, they can begin clear liquids in advance. The complications is definitely a peritonitis, and generally it's caused from a ruptured appendix. If it's going to happen, we see it in 48 hours after the onset. And the symptoms, almost like an appendicitis: rigid board, absent bowel sounds, severe pain, fever, increased WBCs, and unfortunately the child can lapse into shock or even die. Meckel's diverticulum is interesting because they say that this is present in 2% of all children. I read an article that said many of us have a little bit of a Meckel's diverticulum, and when we're older, if our diet is not good, like we're eating like too many nuts, too much roughage actually, it can lead to diverticulitis, interesting enough. But we're talking about little kids, so it's an abnormal pouch of either the pancreatic tissue or an acid secreting tissue from the tummy on the small intestines. It's present at birth in about 2% of all children. It's resulting from the failure of the amyomesenteric duct to fuse during the embryonic development. So it doesn't fuse, so it lets it kind of pouch out. What we see in these little ones is painless rectal bleeding. The key term here is painless rectal bleeding, okay? It's not painful, it's painless. Abdominal pain and bloody mucus stool. Usually they'll do a CBC and metabolic panel. They'll do a radionuclide scan to see if there's gastric mucosa available, and then they'll remove it. Complications for untreated MECLs is actually GI hemorrhage and bowel obstruction. So the kid that's now 6 or 7 that has had mild symptoms or it hasn't bothered them, you know, especially once they're able to go to the bathroom themselves, they may end up with what we see mostly is GI hemorrhage, but it could also be a bowel obstruction. Care for these children preoperatively is because of the bleeding rectally, it becomes like just bleeding, not just blood in their poops, they're bleeding. They become hypovolemic, and so it needs to be corrected, and they might have to have transfusions, IVs. You might have to correct the electrolyte imbalance, and they'll always give them antibiotics. Anything to do with that area, they'll give antibiotics. Because they've been bleeding, they may need oxygen. Of course, they'll be on bed rest. And then you want to observe the stools for blood, maybe do a stool for O and B. Child goes to surgery and is repaired. And so he comes back, and it's at first, once again, normal post-op care. Maintain the airway, check the oxygen level and vital signs. Control the pain and assess the surgical site for bleeding or infection. Once again, the important thing with these surgeries is assess bowel sounds and functions. Continue IV fluids and antibiotics. The child will be NPO post-operatively, and they'll have a suction to low an NG to low continuous suction.
Celiac disease. We see it in older children. Very seldom do we see it in young children. But if we're going to see it in a young child, it would be a child as soon as they start eating foods. So around 4 to 6 months, probably more like 6 months. This is just where the body does not digest gluten, and it damages the cells, or sometimes you call it the villi in the bowel. The symptoms are usually diarrhea, abdominal pain, distended abdomen, weight loss, and then I have the steatorrhea and the anemia as well. It's really serious when children lose weight. So if a kid has constant diarrhea and they're starting to lose weight, there'll be some inquiry on why this is going on. Foods to avoid that will irritate this bowel is oats, rye, wheat, barley, and malt. And then I did write down a few things that are okay, because for some reason people think that these foods like rice and potatoes are not okay for celiac disease. And actually, that's what these kids live on, you know, are these foods. And these are healthy foods. So celiac disease, if it's handled correctly, it the child will be a very healthy child. If not, they're going to constantly have that abdominal pain. And I believe it occurs, now some of you that have celiac disease can tell me, shortly after they eat, the pain begins until they're treated.
There's a lot there. There's an awful lot there. However, I would personally make a chart with each one, and the one thing that makes them stand out. All of these problems can lead to dehydration. So that's why I started with dehydration. Mostly these particular situations are caught pretty early. It's the gastroenteritis ones that definitely lead to one type of dehydration or another. So personally, I would make some charts on what each one of these anomalies are, what their symptoms are, and what's done for it, and any special nursing care. Remember, most of the nursing care for the anomalies are the same post-operatively. Most of the kids come back with an NG to suction, and then, for a few hours, then they take it off. Once their bowel sounds return, they are fed clear liquids and the diet's advanced. Remember that the kids on gastroenteritis are not given the Brett diet any longer. And that's a wrap. I hope this was fun for you.